Hey y'all, it's DJ Nurse Bauer. Shout out to Jordan Sparks for reining in our first basics mashup, Breathe. During this mashup, we will follow our patient, Mr. Jones, through the basic nursing concepts. Stay tuned for Breathe. As we assess the landscape, we see the rise and fall, uneven and even, which one to call. How is this landscape similar to our lungs? Take a look at it. What do you think? We have some clear skies. We have a little blip here and there. That could kind of be like our, a little wheeze, okay? Coarse lung sounds, it kind of looks like those craggy edges with those peaks. We have peaks and falls, the rise and fall of the chest. When we think of the lungs, we're definitely thinking about the assessment, okay? So the anterior and posterior thorax, these are the landscapes. They're pretty cool. Let me see if I can get my pen working today. Okay, so thoracic landscapes. So this mediasternal line. So look, midsternal. See midsternal. Okay, that's the sternum right here, and that's midsternal line. The right midclavicular. So mid, so middle, clavicular. See that I mean? Clavicular right here. And then the right anterior axillary. So anterior axillary. Okay, axillary. Okay, posterior axillary, you see how that works? It's over here. Anterior axillary line, it shows you. Then the mid-axillary line, it's right, this is your axillary right here. So you kind of need to know where these things are, like these first ribs. It's pretty high, right? The right upper lobe of the trachea, thyroid cartilage, all these little landmarks are really good because then we're going to know how to listen to these lungs and where you might hear a rib. You kind of need to know where those things are so it doesn't sound dull and you're not documenting something that you might miss. Assessment. Assessment is always going to begin with health history and a review of the systems. Okay, some of these are definitely going to be focused. So for our patient, Mr. Jones, he's having some shortness of breath. This is an ongoing issue. He also has some arthritis. So just kind of keep that in mind while we're walking through this. He technically has a diagnosis of COPD. So just think of the things that your patients would have if they were short of breath. And that's like our nursing diagnosis is the shortness of breath, fatigue, perhaps irritability. So those are the types of things that we're going to look for in these types of patients. History review of symptoms, chronic lung conditions, so that would be our COPD, history of pneumonia, whether or not the patient had had pneumonia before or has it now, extended coughs or colds. These are things that you're definitely going to see in your chronic lung patients. Frequent cold or cough. Again, extended cold, frequent cold, usually they kind of go together. History of shortness of breath. Anytime a patient is short of breath, that's something that needs addressed. Smoking, lung cancer, tuberculosis, vaccinations. Why are vaccinations important? Hello, respiratory problems. Okay, we're going to do a pneumonia vaccination. We're going to do a flu vaccination, right? So those are both respiratory issues that can harm your patient. So let me go ahead. The assessment, the way you want to do it, you're going to assess, you're going to inspect, you're going to palpate, you're going to percuss, and then you're going to auscultate. Okay, so we got 4 Mr. Joneses over here, but each of them are a little bit different. What are we going to look for? Okay, we're looking for shape. Anterior posterior diameter is 1/3 to 1/2 of the transverse diameter. Yes, that sounds like a bunch of junk. However, if you take a look over at normal versus barrel chest, okay, you can definitely see the difference, right? So you can see that the barrel chest, the chest is definitely The same way down, it's larger. Okay, the normal chest is definitely different than the barrel chest. Pectus carnitatum, I always say it wrong. If you notice, the bone is protruded out, and you can see that it's not in the normal range, so you can't see just the deviation between the two breasts on the sternum. And the pectus excavatum is when there is a cavitation, so therefore the bone goes deep down inside of it. So those are just some chest things and that you would want to take a look at, those thoracic abnormalities. Symmetry. You got to look for the deformities. You have to look to see if it's symmetrical. If one side of the chest is rising and the other side is not, that's definitely a problem. Respiratory effort. 12 to 20 is normal per minute. We see patients getting tacky up into about the 24s, 26s. This is not normal. Character, we're looking for abdominal and thoracic. Some people take really deep breaths, short breaths, hiccup breaths. They want to take those really short breaths that you'll see way up in the chest, but their abdomen isn't moving at all. Use of accessory muscles. So you'll see that everything is working. These patients, their entire chest is working when they're trying to take a breath. All of the kind of looks, I kind of think it's like a fish out of water. You can see the gills moving. It's kind of like a patient will look like they have gills because they're using all of those muscles, and you can see them going in and out when they're trying to breathe. Expansion, we're definitely going to look both sides to see if it's expanding. A cough, is it productive or non-productive? What does that mean? Is there sputum? You coughing something up? What color is it? If they are, how do we get it out? Those are things that we're going to need to know for an assessment piece. So for example, if we go ahead and suction a patient, we have to put it on the documentation that what we use to suction. Did we use a yonker, which is just to put it in the mouth, or did we use a tracheal suction? Did we use a nasosuction, so through the nose? Did the patient cough and then just spit it in a cup for you? We're going to need to know those things for the assessment purpose. Assessment continued. Palpation. You want to palpate for tenderness. Yes, your patients will let you know when they're tender. When you say, I've had a lump over here and it's just different. Deformities, any type of deformity, well, I've had that since I was born, or, that just kind of showed up. Those types of things are going to be important for your patients. Expansion of the posterior thorax. It's really easy to not have your patient kind of sit up because they're not feeling good. Sometimes we just go ahead and you can lay there in the bed. However, you gotta see the expansion of both the front and the back lobes. You just have to, the front and the back of the lobes, because there might be a part that's not working that you wouldn't be able to assess otherwise. Vocal or tactile fremitus. So what you want to do is you want to palpate the chest wall with the palms of both hands. So you want to put your palms on the chest wall and ask the patient to say 99. And at each time you're going to move your hands down. So 99, 99, 99, 99. And you'll be able to feel that. Percussion. Compare sound from left to right side. Tap on the lobes. Expected findings are dullness and hyperresonance. Unexpected findings, I apologize. Unexpected findings are dullness and hyperresonance. So dullness is that like thud instead of a dum dum dum. And then hyperresonance is that bounce. It's like boom boom boom, like a drum. This is a pretty cool slide. It has assessment continued, but it gives you the order of the auscultating your lung sounds. So that's your anterior and your posterior views. You're looking for the bronchial sounds, the bronchiovascular sounds, vesicular sounds. Okay, and your adventitious sounds are your crackles and rails, your wheezes, rhonchi, pleural friction rub, absence of breath sounds. These are also some breath patterns that I think are pretty cool that you might need to know. Let me get my green lasso around here. So normal, tachypnea, bradypnea, hyperventilation. That's when everybody says, I'm hyperventilating. Rapid, deep respiration breaths of the respirations are above 20. So it's pretty easy to hyperventilate when, especially you're not feeling good. One of the other ones, air trapping. This is important. Our COPD patients, our emphysema patients have a hard time, difficulty during expiration. Okay, so blowing that air out, that okay, so this is where your education skills help you, because since you know that these people are trapping air, we use the pursed lip blowing to help them get that air back out, because it's hard for them to push the air back out because they actually don't have that incentive to breathe any longer. Their body's like, I have enough oxygen in here, it's just stuck. Okay, so what we need to do is we need to expel some of that air for them, that and forcefully blowing it out with pursed lip breathing definitely helps them. Optimal O2 status. We're talking about a regular patient, okay? I'm not going to go into the COPD pieces and such for this class. Generally, you want to keep your oxygen above 90 for your patients. Oxygen therapy, if patients are on O2, assess the amount. So you're going to want to look and see how much oxygen they're on. If they're on 1 liter, 2 liters, 3 liters, our goal is to put them on the least amount of oxygen that they need in order to get a positive result. Assessing the route, nasal cannulas, venti masks, non-rebreathers, trachs, vents, BiPAP, CPAP. These are all things that you need to know. Over here on your right, you'll see I put some different types of oxygen masks and for the trachs that you might come across. This is technically an OptiFlow, is a high flow, and you'll see that in a lot of our end-stage COPD patients. They need a larger flow. This is before they get to an intubation, before they get to where they need that higher flow of oxygen all the time. And we like to manage our end stage people this way because it's more comfortable for them. Tracheostomy interfaces, you'll definitely see some people don't have to have oxygen, but they need the cap on there. We need to keep it hydrated, because once those secretions dry up, that's when there's clogs and the trachs become dry. Adapters with the oxygen masks and the adapter with the trach mask. The vent trach mask is definitely what keeps that air, that oxygen moist in that airway. Assessing perfusion. So one of the biggest things is we're going to look at their skin. We're going to look and see if their skin's blue, if they have cyanosis, if they have any problems with their circulation, with their perfusion, with their oxygenation. It kind of all ties together. How is this helpful for Mr. Jones? Well, Mr. Jones is puffing away and he is getting a little blue around his lips. Okay, so we might need to give him some oxygen. He doesn't have any oxygen at home. He's not at that point, so let's try maybe 1 or 2 liters to see if he can feel any better and we can get him more comfortable. Look to the sky and breathe in the night. The snowfall blankets the foliage, and we wonder, how do we manage? A lot of times our patients kind of feel this way, feel like the snow is falling down and there's nothing that they can do about it. But yet, sometimes we have to pick them back up and show them that there is a way. So for Mr. Jones, it's not just about his breathing, okay? So now he's in a stressful situation, he's not breathing well, and let's say he has a headache, he's not feeling good, he's prone to getting migraines on top of all these issues. So now he has a sensory perception problem. We didn't get much about his history, so we don't know if he has hearing or seeing issues yet, or any neurological problems. A lot of people will have vertigo. But how is this landscape, like we did for breathing, similar to our senses? What are the things that we can sense in this picture? If we were standing in this landscape, what would we see? What would we hear? What would we feel? Probably would feel cold. We might smell the snow, that crisp air. Might burn our lungs, might be something that it would do, but that cold air going into our lungs like that. We might be able to hear the wind. Those are things that are important to our patients. And when they lose those senses, when they lose that perception, there's definitely some grief and some loss there that we have to be cognizant about, because when we lose our senses, some of them get heightened, but some of them may not. So it's definitely a change for our patients. So poor Mr. Jones is having an issue. He, this is his sensory overload. Okay, he's now got a headache. He is dizzy. He is having vertigo. He can't handle any more stress. He can't handle it. Oh, and by the way, he forgot to tell you that he was hard of hearing. So over here is our hard of hearing on your right, and then our sensory overload. We talk about sensory overload, but we kind of have that in the hospital a lot. So our patients come in and they're not feeling good. They can't listen to us. They're in pain. They can't see much. They're not touching. Everything they smell is awful. They can't see. They're just, everything's terrible. See how that's kind of an overload? Even when I say it, you guys are like, okay, calm down, Miss Bauer. So what's happening here is our senses. A sensory overload can come from a lot of different things. It can come from, for example, an amphetamine overdose. It can come from migraines. It can come from um, just being overwhelmed with your current condition. Stress can overload. So, but our autism people feel like this a lot. They say that that's one of our sensory problems. So if a child, they say, my child has sensory issues. This is one of the things they're talking about. A lot of these things are just overloading these kids or these patients, these clients, including sense of smell and taste. Some smells just make, do you ever have a smell that just makes you want to throw up? This is heightened for some of these people, and then sometimes they can't even stop it. So if they smell something while they're having that migraine, they might just go ahead and vomit. In the middle here, we have sensory. This is actually a description of vertigo, what vertigo feels and looks like for somebody. It just looks like a spinning. Which this is actually an inner ear issue, but it's considered both because it's a hearing thing. It's a problem with your inner ear. However, it's affecting your sense of sight. You look at your sight, you can't really see very well if it's all swirling around. Another thing is, so in sight, for people with that sensory deficit, most of the time their other senses kind of pick up for it, which is cool. But we need to be cognizant of these types of sensory perceptions for people. And also we need to make sure that our patients and our clients have their glasses if they need them, or we're putting things in a proper area for them. If they have to read something, please turn on the lights. Some people don't like that much light, but so go ahead and ask, hey, do you see better with more light, or do you kind of like it kind of dim? Because sometimes that will sensory overload them. And hearing, for example, someone that's having a sensory overload, we wouldn't want to put them with somebody that is, let's say, hearing impaired, because they might not know how loud they're being. And it's the same with someone that's having a migraine. Let's say we wouldn't want to put them with someone that has a sight impairment, because again, they're not going to know, hey, maybe the light is on, and or maybe they need more light to see. So those are some things that you want to keep in mind when you're caring for your patients and managing your patients. Comfort, acute and chronic. So Mr. Jones, we finally getting him settled in. We got him some oxygen. He's feeling a little better, but he still has some pain. So we kind of have to assess what is going on with Mr. Jones. Mr. Jones is having pain, but we have to kind of decide whether or not his pain is acute or chronic. So pain that only lasts through the expected recovery period, 30 days to 6 months, would be considered acute. So for example, Mr. Jones is having some pains in his chest due to coming in and coughing. So when he coughs, it hurts. While he could have a chronic problem, this exacerbation, if you come in with an exacerbation, we're going to consider that acute pain. So this varies in severity, location, and etiology, but it can elevate your blood pressure, increase your heart rate, cause nausea and vomiting, sweating, rapid respirations, anxiety. Well, if I couldn't breathe and it hurt, I bet you I'd be anxious too. So decrease in function of daily living activities. So let's say Mr. Jones is having a problem and he's, got sick again and he's coughing, coughing, coughing. How do you guys feel when you're coughing, coughing, coughing? You don't want to really do much, right? Can elevate your blood pressure. So even if he doesn't have blood pressure issues initially, his blood pressure and his heart rate might be up. Vomiting. Have you ever noticed anybody ever feel nauseous when you're in pain? A lot of people cut themselves if they have a deep cut, and then they'll feel nauseous if they look at the cut. Sometimes pain can do that to us. Chronic pain. Chronic pain lasts longer than 6 months and persists beyond the expected recovery period. So Mr. Jones also did complain of his knee. Oh, this knee just hurts. This knee just hurts. And then you ask a little bit more about the knee and what's going on. Oh, did you fall? And he's like, no, it's just, it's gotten worse over the years. I've had pain in that knee for probably 10 years now. And that would be it. Expected, it persists beyond the expected recovery period. So that would be a chronic condition. It manifests depression, irritability, impaired mobility, and activity, sleep disturbance. So let's go back to the COPD side of things. So chronically, this patient is short of breath and getting sick. Okay? So chronically, not really feeling good. So irritability. Yeah, if I couldn't breathe, I'd probably be irritable. Depression. So if you weren't able to do the things that you wanted to do any longer because you couldn't breathe, you're getting short of breath, you're going up the stairs. Let's say you really like to play ball. A lot of people like to go run, or they like even allergy season. You'll see a lot of people get super irritable when allergy season comes around, okay, because they can't do the things that they want to do, and their mobility or activity is impaired. Or sleep. Anybody try to sleep when you have a cold? Okay, how do you think these patients feel all the time? They have one of these chronic issues. Their sleep is definitely disturbed. So for interventions and therapies for acute pain, notice we're going to do pharmacologic and for both acute and chronic. And they're pretty much the same except for we have opioids, non-steroidal anti-inflammatories, and non-opioid analgesics. Okay, so we have those on the acute side, and on the chronic side we have a couple extras. We have muscle relaxants and antidepressants. Ooh, antidepressants. So antidepressants are known to help with chronic issues. So chronic pain receptors, it definitely changes your mindset, it changes your body, it changes the way you react to pain. And long-term pain, chronic pain, does lead to depression. Muscle relaxants definitely help as well, because a lot of times your body compensates for certain areas that might be painful. So in certain circumstances, a muscle relaxant might really help for chronic pain management. Non-pharmacological therapies, we have massage, music, involvement in hobbies, aromatherapy, heat and cold applications. Um, they're pretty much the same for the chronic side too, except for we're going to start doing like guided imagery. We're going to do nerve stimulation units, those TENS units, chiropractic interventions, especially for back issues, um, and deep muscle issues, your relaxation techniques, your positioning. Now we're going to continue comfort with fatigue. Fatigue is a lack of energy or motivation with or without drowsiness. So acute fatigue, okay, that's like I stayed up way too late and now I had a poor night's sleep. This was a stressful experience. I should not have done this. Ms. Bauer, I stayed up all night studying for my test and I should have gone to bed. Um, but it's able to be resolved. Okay, so quickly begins and then quickly resolved with adequate sleep and rest. So I got something to eat, I took a nap, and now I feel better, or I'm at least feeling better. It might take you a few days to recover. We treat this with adequate rest and sleep, adequate nutrition and hydration. So all those things that we talk about, rest, helpfulness, promotion of proper sleep. Chronic fatigue, more intense tiredness that lasts longer than acute event. So this is like I haven't slept for a couple months, exacerbated by physical activity and mental activity. So mental activity, I always say that I'm either physically tired or mentally tired. And a lot of the times I'm more mentally tired than physically tired. And I still want to sleep. Usually caused by long-term illnesses or medications to treat illnesses. You'll see this in all of your chronic illness patients. That chronic fatigue lasts more than 6 months, accompanied by joint pain, headaches, sleep, and memory problems. That's your chronic fatigue syndrome. So that's definitely something that I think all nursing students might be experiencing at this particular moment. However, we also want to take a look at the things that are going on. So another one that a lot of people have questions about is fibromyalgia. Okay, how do we tell what fibromyalgia is? Well, this is how. Often it's associated with rheumatoid conditions, and it's characterized by widespread musculoskeletal pain, fatigue, sleep disturbances, and psychological distress. And it's diagnosed by a test of tenderness. There are 18 tender points that are located throughout the neck, shoulders, chest, hip, knee, and elbow. And we usually treat this with symptoms. So if the symptoms are getting worse, then we treat the symptoms. A lot of times they will put patients diagnosed with fibromyalgia on antidepressants to help battle this, because the antidepressants, when your body's depressed, it does not cope well, and pain is one of the things that gets worse. When you're stressed out, you feel pain more. So your body is stressed, it's going to feel that achiness more. So it's definitely important for our fibromyalgia patients to get on some type of antidepressant or actual treatment of the symptoms of this pain. A lot of times it is nerve pain, so you'll see things like nerve medications, like Lyrica. However, sometimes a non-steroidal, just ibuprofen, go ahead and take that, will help. Guided imagery, a lot of distraction for the non-pharmacological interventions definitely help with these patients as well long term. Sleep. Oh, glorious. Sleep and the loss of is treacherous. Loss of sleep is the duration of sleep shorter than the recommended 7 to 8 hours per night for adults. I don't remember the last time I saw 8 hours. That's probably because I have toddlers. However, some of the problems with sleep that we see, these are the most common: sleep apnea, insomnia, narcolepsy, parasomnias, and restless leg syndrome. Okay, so we're going to go right down. Up for grabs is sleep apnea characterized by breathing pauses during sleep. Okay, breathing pauses during sleep. So these patients stop breathing during their sleep. Yep, that might cause a sleep discrepancy, okay? Especially if your body's like, whoa, and it keeps waking you up. It's pretty cool that way. Your body will pretty much wake you up um, out of like a deep sleep, even if you stop breathing. So treatment, CPAP, a continuous positive airway pressure machine. I've definitely seen BiPAPs too. Ventilators, excavation of the tonsils and the adenoids. So a lot of times they'll go in and take those structures out because a lot of the times this is caused by a relaxation of the muscles in the neck. So it's they get so tired and they're so sleepy that airway collapses. This also happens with bulky guys or women as well, heavier side from just weight alone. Next is insomnia. I think we are all a little insomnic right now, characterized by difficulty falling asleep, difficulty maintaining sleep, or short duration of sleep. So those people that are coming in at 3 hours of sleep, you are still an insomniac. For those people that can't fall asleep, it takes you forever, you're getting there. And then the difficulty maintaining sleep. I know some people that say they sleep for like 10 minutes, they sleep for an hour, then they're back up, and they do this a couple times a night at least. We're hitting the insomnia stage if you are not hitting that 7 to 8 hours of sleep. Narcolepsy. This one's an interesting one. Excessive daytime sleepiness, even with adequate sleep. So you can sleep 12 hours and still be tired. Results in sleep attacks. Ooh, and cataplexy. What is cataplexy? I had to look it up. Strong emotion or laughter will cause physical collapse. These patients will literally collapse from laughing or from a strong emotion. So if you're super tired and then stressed out, this person can collapse. That's pretty dangerous, right? Parasomnias, characterized by unpleasant or undesirable behaviors. These are your sleepwalkers or your night terrors, your sleep terrors. This is terrifying for these little ones that have these things and then they don't want to go to sleep or can't go to sleep. I've definitely had sleepwalkers too, and that's a scary thing too. You need to lock all the doors, and some people know how to unlock them in their sleep too, which is terrible. Next is restless leg syndrome, characterized by neurological disorder. So this is an actual neurological disorder, results in irresistible urge to move their legs and other body parts. So it doesn't necessarily have to just be your legs. Some people have their arms, their toes, their elbows, those types of things. They feel like they just have to move. Often causes impaired sleep habits. Yeah, I definitely could see how that could be a problem. So how does this correlate to Mr. Jones? Well, Mr. Jones can't sleep. So he's probably up all night, and he had told me that he just can't seem to get to stay to sleep. And he doesn't know, but his wife said that he snores terribly. So the two things that we might need to look at him for that would be insomnia and our sleep apnea. We might need to send him for a sleep study. Treatment of sleep and rest disorders. Okay, how are we going to battle this? We're going to try to improve their sleep hygiene. What do I mean by sleep hygiene? Okay, sleep hygiene is a routine. We need to see what we're doing to try to get ourselves to fall asleep and to have good sleep. Whether or not that is wearing the machine for sleep apnea people, that's putting a couple pillows behind you to make you more comfortable, that's getting the temperature right in the room. It's also establishing a routine for bed so that your body knows that it is time for bed. Having a bedtime, having a schedule, reducing your stress. These are all things that are going to help improve sleep hygiene. Pharmacological therapies, those are the sleep gummies, those are the all of the medications that they have for sleep. We try to keep these for last because once a lot of people are start on those medications, they really have a hard time weaning off, or if they ever wean off at all. Relaxation techniques. They have chill drills for the military. They have all kinds of different apps for sleep and relaxation that will help you fall asleep, that will help you get into those better sleep habits. And your assistive breathing devices, those are your CPAP machines, some people need a ventilator at night when they sleep. So I know it sounds silly, but their bodies just relax so much, they definitely, or have that mechanism is gone, so they have to go ahead and use the ventilator, use the different devices at night. Stress and coping and grief and loss. How we cope with stress affects everything. I really like this slide because it kind of shows us stress including an event, appraisal, distress, any type of thing that can cause stress. Even good things cause stress, like babies are good things, they cause stress. Um, Physiological mechanisms cause stress: hormones, blood pressure, immune system. It affects everything. It affects your healing. It affects how sick you are. Disease, cancer, heart disease, health compromising behaviors. These are things that you can change. Smoking, drinking, poor nutrition, and lack of exercise are things that we can change. That would help with our stress. Coping. Look at it here. It has inside and outside. So we need a balance of both. We definitely need to get outside. The daytime, we have to keep a schedule. Notice there's a little time thing on here in the bottom. Extras, you've got to see where your extras are and maybe work around reducing, or maybe you need to get out there more. Rewards, we definitely need time to reward ourselves too. I don't mean food or drink, okay? However, sometimes we need to reward ourselves. Maybe it is just a relaxation day, or a day for you to clear your mind, go for that walk, get moving, go ahead and get that healthy meal, go ahead and do those things that you want to do, because the more that you're able to manage your stress without there are bad habits or coping mechanisms, then the better we're able to manage our health overall. So we're going to talk about Mr. Jones. Now we have gone through stress, and now he's stressed out, but I think we've got him taken care of. We got him on some medication. We got him on some steroids for his lungs. We've got him on a little bit of ibuprofen for his knee. We got him sitting up nice and tall in the bed, so he's breathing better. He's got a little bit of oxygen on him. Now we can talk. Okay, now that the acute exacerbation is kind of managed, we can go ahead and start talking to him about what the next steps are. So this is our management of care and our legal issues. So delegation is a big thing with managing care. So our unlicensed personnel, we cannot delegate assessment, teaching, medication, evaluation, and unstable patients. Now, a licensed personnel such as an LPN, we would definitely be able to give an LPN this medication piece, okay? So I'm going to circle that for you, and I can say LPN. My handwriting on here is terrible, okay? However, we're still not going to give them an assessment or a teaching or an evaluation. An unstable patient, it would depend on their specialty, but we're probably not going to give them either. But the medication piece, yes, they can definitely go ahead and do that. The 5 rights of delegation: right task, right circumstance, right person, right direction or communication, right supervision or evaluation. I really like this because this is our teamwork. This is our delegation process. You know, RN delegates tasks to CNA, patient must be stable, delegate tasks to qualified personnel. So that's our LPN that can do our med pass for us on that patient that's stable in the other bed while we take care of this unstable patient. Explain specific task at hand. Hey, I really need you to give Mr. Jones his medication because he's feeling okay, but I have to go deal with Mr. Scott who is just having an MI. Provide feedback and thank for the assistance. Tell your people that you care about them. Thank you very much for your help. I really appreciate that. The patient stated that they're still in no pain because you went and you helped me out. So I appreciate your help. So back to Mr. Jones. We start discharge planning when they walk in the door. It begins at admission. Planning, planning, planning. Assess expected residence return. Okay, so Mr. Jones came in and he has this COPD exacerbation. Is it something in the house? What kind of residence does he live in? Can he go back there? These are the types of questions that we might see that we might want to talk to him about. Okay, so Mr. Jones has been living in the same trailer for the last 40 years. It has never been updated, and he was thinking maybe it was time to leave. Well, you send an inspector out there. A lot of times our home care nurses are able to do site care visits, which are really cool. I used to do that. And I've gone into some places that have had mold, black mold growing up the walls. So, which is interesting because that would definitely be a healthcare problem for this patient and for any patient. So we have to look and see if it's you're able to go back to the residence. So, well, then we found out that it was the wrong Mr. Jones that we were looking at. And Mr. Jones that we were talking to, that's our patient, he lives in a residential home. So he has a brand new, just bought it last year, new home that he worked very hard to get, and he wants to live in the rest of his life, and he'll call assistive personnel to come in there. Perfect. So he can go back home. Okay. Determine the client support system for return to home. So his wife lives with him, and he also has a couple daughters that will come to help. And he also has insurance that allows him to go ahead and get those assistive personnel if there's a need. Assess the home needs and appropriateness. It's a level 1-story home. Now, if it was a 2-story home and you needed to go upstairs, up and down the stairs a lot, we might need to look at that and make a room downstairs for him. Social worker referrals. He really doesn't have rides back and forth to his physician's offices because his wife still works. And right now, to get back and forth, he can't drive himself, and he might need some extra help with that. He also might need oxygen now, so maybe the social worker could help him with those those pieces of this discharge planning. Provide adequate documentation. You got to document what you were doing for this patient, and that, like, for example, that you placed him on oxygen and he's unable to come off of it. You just can't get him off that 2 liters that we put him on. Every time he comes off, he's definitely going down much lower into the low 80s. Advanced directives. This is the time we need to talk about these things. These are hard conversations to have with our patients, but as the disease progresses, with any disease, we have to talk about age, and a lot of our older population don't want to be resuscitated. Must proceed unless official DNR ordered. Okay, so we have to talk about to our patients, hey, is this what you want? And go through all of the stages and what CPR really means and what resuscitation really means. Once you go through those things, they have to understand that unless this is an official order, that we will still have to resuscitate legally. Management of self. and education. We have to identify new client status. So we have to see where they are now. Okay, so we got you through the acute exacerbation. Are we any better off than when you came in? And how are we going to make sure this doesn't happen again? A lot of times we send in home care for this so that we can kind of keep our patients at home instead of bouncing back into the hospital. Identifying home safety concerns, which we did, the trailer versus the residential home, and to see whether or not that's a problem. Review of systems of complications and exacerbations, okay, and when to call the physician. So sometimes our patients get anxious and they say, well, I'm just not feeling good and this and that, so let me just go into the hospital. But what we want to do is we want them to gauge, and we want them to be able to self-manage until and when they meet certain criteria, that's when they would call their physician. Provide phone numbers for the providers. We want to provide their community resources if there are any. Provide step-by-step instructions for your continuing treatments or your medications. And you want to provide the proper equipment. So if the patient needs to go home with oxygen, we want to make sure that that oxygen is actually set up, and your social workers and your care managers can definitely help you with those processes. Advocacy and accountability. Advocacy and accountability. So what does this mean for Mr. Jones? Okay, so he has decided that he wants his advance directives. Okay, so we're going to support that patient's decision with him, but his wife doesn't really appreciate it, and she just doesn't understand why he wouldn't want a feeding tube. So we're going to need to support the patient's health and wellness and his safety, personal rights, and including his privacy. So this is a decision that our patient made, and we have to say these are the benefits and these are the downfalls of this particular decision. However, supporting that patient might be one of the best things that you do for them, because sometimes their families are not on board. Another thing that's really interesting for advocacy is our informed consent. Informed consent. So let's say Mr. Jones is in there and all of a sudden he gets a super bad pneumonia, and for some reason the doctor is like, okay, we need to do a bronchoscopy and we need to go in there and wash out his lungs. Ooh, right? That sounds terrible. Okay, so patient is sitting there and said, yeah, I'm supposed to have something done today. It is the physician's job to complete the consent, okay, and the nurse is to verify. If we cannot find that verification, we cannot be done. So we have to go back. It's part of the advocacy for the patient's rights. They have a right to know that this is the procedure. So the doctor has to come back in and tell them what this procedure is about and why we're going to do it. Mr. Jones, I'm going to come in here and I'm going to do a bronchoscopy. We're going to put you under light sedation, and we're going to put a tube down your throat, and we're going to wash out your lungs. And then we're going to take the rest of it and suck those little pieces out that are sitting in your lungs that are causing you pain and discomfort. Well, the patient might think, oh gosh, washing out my lungs, this sounds terrible. I really don't want this. Is there something else we might be able to do? But we wouldn't be able to know that if the physician doesn't go in there and actually talk to the patient about this problem. And a lot of the times informed consent is done with the nurse. So the physician asks the nurse to come with them and make sure that everything is verified. The patient has the right to decide. So let's say he decides that is not a good idea for him, and Mr. Jones decides, let me just do steroids and antibiotics and we'll see how it goes from there. And he has that right. So medication management, That's another big thing. A lot of patients really hate this pill or that pill. We just kind of need to find a better mix for them. A lot of times an organizer just helps, but they definitely have the right to decide. Uh, Being accountable, the ability to answer for one's own actions. Okay, we need to be accountable not only for us but for our patients. We have to respect our patients, be honest to them, keep our integrity in check, keep our ethics in check, so that our patients can have a great experience with us and with our hospital. So thank you for tuning in to Breathe the Mashup. I hope you have a great day, and I hope you learned something. Happy studies!